Questions so far? All right. Degenerative diseases. This is where parts of the brain are starting to get destroyed. They're starting to degenerate. Dementia. Good example of this, right? It's a condition of being without the mind. You're here, but you're not here. Almost like sometimes when you take my exams. You're here, but you're not there, right? No, that's not it. Dementia. This is, again, the feeling that, you're talking with a person and they're just not there talking. When many neurons the cerebrum itself are dying, the cerebral cortex actually shrinks. This is as we get older. You're thinking that things like just senility, Alzheimer's disease, that kind of stuff. Your memory is usually the first to go, the first symptom on here. They don't usually die from that. They usually die from other things because the whole brain starts deteriorating, right? Okay. But you could change the way you do things, right? As you get older, like here, this is the way our brains look at 30 years old. Here's our brain at 70 years old. Just something to look forward to. We lose the weight of these certain things. So your brain will just gradually start dying. Those neurons start dying. They have a lifespan. But that doesn't mean that you can't be, with it and understanding things and keep your mind going. There's always neurons that have not been fired inside your brain for eons. You just haven't used them. You've been just using the same neurons and they're firing a certain way. But there's a lot of other neurons that you haven't used and you are not used to using them. And that's why it hurts when you start thinking, especially in this class, pathophysiology. It's like, I don't know, it hurts my brain, right? So let me give you an example, okay? To show you that you can use neurons that you haven't used before. Tell me the months of the year in alphabetical order. Yeah, you see? You're using your brain differently. This is what's happening with people as we get older. That they want to use parts of their brains that they're not using. That's why we see older people playing chess, doing the crossword puzzles, reading the Bible. Well, they're probably trying to get into heaven. But no, I'm just saying that they're using different parts of your brain. And that's what I'm saying is with pathophysiology, it all comes back to this. If you're wiring your brain to think clinically, it's going to be second nature to you. That when you get into these other courses, when you get into your career, that you're already thinking that way. And it's hard. It's just being able to rewire your brain or use those neurons. I can guarantee that, for that example, about tell me the months of the year. I'm like, oh, I'm afraid my brain's going to ooze out of my ears. And no, they're not. But I can force you guys to know it because I can say, I'm going to do an oral quiz next week. You got to tell me that in alphabetical order. Sure, now you'll do, right? You'll do it now.
Yeah, but that would boost our grades so much.
No, but that's what I'm saying. There's an incentive. In other words, we always could take, I could lead the horse to the water. I can't make him drink, but I could put salt in his mouth, make him thirsty, right? And that's what we're doing here, right? So what I'm trying to say is that, yeah, you got to learn new ways. There's a bunch of neurons that you just haven't used. You haven't wired them a certain way. You have to get those wired a certain way, though. Like right now, if I said to you anterior and posterior, oh, that's no problem. But go back to when you first learned those terms. Distal and proximal. Oh, my goodness, right? Oh, my goodness. Learning about antebrachial and the cubital. Oh, my God, I can't do all that, right? But look, your brain has been wired. Go back and talk to your mother or talk to other people who are in the medical profession. They're like, wow, you know everything about this. Oh, it's pretty basic stuff now, right? That's what I'm saying. You'll get into that. You've got to just wire those brains, or those neurons. So here we got people, who's this? Yeah, because you all read what it is right now. You know. Ronald Reagan. This guy over here, from TV show Columbo, Peter Falk. No? Charlton Heston over here. Not the Planet of the Apes, although that was probably one of his bigger movies he did. It's not about him. It's about Charlton Heston. All these people here have Alzheimer's disease, or had it. These are all dead now. Now, I pick people over here because I try to, like I said, I always try to put celebrities up here so that people would know them. But I have a relatively young crowd here. It's like, you're not going to know any of these people over here. One of these days, I guarantee, one of these days, when you become a grandmother or grandfather, you're going to say, oh my God, to your granddaughter, you're going to say, can you believe that about Justin Bieber? He has Alzheimer's disease. Like, Justin Bieber, you're old, Grandma. Who's that? That's what's happening now because you don't know these people. Right? Because Alzheimer's disease doesn't happen until about 60 years old. So I'm not going to pick someone that's going to be young and have Alzheimer's disease. It doesn't happen. So I had to pick people older than, I guess this crowd doesn't know. But Alzheimer's disease, this is the most common cause of dementia. It is the sixth killer in America. Now I want to also say something about these. Remember how I keep on emphasizing these killers in America. Wow, all these so big on this thing. I will guarantee, my life is on it, that you need to know those 10 killers because that's what's going to be on your NCLEX. Why? Because these are the people coming into the hospital, coming into the doctor's offices. They want to make sure, the nursing program, they want to make sure that you are familiar with the killers in America, the common things. Is Down syndrome going to be on it? Yeah, it's going to be on there. Maybe a couple questions, but you bet heart disease, #1 killer, you're going to have like maybe 15 to 20 questions on that. So you need to know. That's, people always ask me, like, how do I study the NCLEX? Well, know the 10 killers. Know the 100 most prescribed medications. Those are the ones that are going to pop on the exams. They're not going to ask you the rare things, and if they do, that's 1 or 2 questions. They're going to ask you a lot of questions on common stuff, okay? So this is the 6th killer in America, which surprisingly, it's like, well, if you forget, it's not about forgetting, although you could forget to turn off the stove and you burn down your house. I understand that. But what happens is the brain starts deteriorating. And when it starts at the cerebrum, and then it goes to the hippocampus, and you get forgetful. Soon it'll go to the brainstem, and then you can't breathe. And you die in your sleep. Okay? So it's an increasing incidence, I think, because people are living longer now. But 1/3 of people over 85 years old have Alzheimer's disease. That's how big it is. Okay? The way to diagnose it is autopsy. You're not going to cut open someone who's 85 years old and do an autopsy on them. If it looked like Alzheimer's or some kind of dementia, let them be, it's fine. But they have to look for these neural fibrillary tangles, which are found in the brain itself. Okay? But who's going to do an autopsy? Nowadays, people only do autopsies that have no clue about why that person died, like a 5-year-old, just suffocated, whichever, or foul play. Those are really the most common reasons why people do autopsies now. Right? But if there's a diagnosis, dementia or multiple sclerosis, there's no reason to have the family go through like an autopsy with that person. Right? Okay. So these are other causes of dementia. Just senility will do that. Having many strokes. Brain trauma, alcoholism, drug abuse, as you see, like Ozzy Osbourne, that's a perfect example. I should put his picture up there, what drugs do to you. What's that?
Eric Clapton, too, I watched it.
Yeah, he started to, so you gotta, so all these things. So it's fine if you want to do it now, not that I'm encouraging drug use, but you gotta worry about what's gonna happen to it. No, it's not fine at all. But what happens is later on, you know what I'm saying? You're playing funny games now, but, you kill nerve cells. Parkinson's disease, Huntington's chorea, which we'll talk about too. All right, here's Huntington's. So Huntington's chorea is an autosomal dominant disease, again genetic, okay? It puts these amyloid-related proteins in the basal ganglion. Now, what does the basal ganglion do? It does, well, it initiates movements, it terminates movements, but more importantly, it also prevents unwanted movements. So if the basal ganglion is affected over here, they're going to have unwanted movements. So they have these dramatic, uncoordinated, writhing body movements that it's almost like they're doing a disco dancing. It's really graphic, really dramatic, all right? So bad that they don't even want to live. They get depression, and a lot of them commit suicide with something like this, all right? Hypertonicity is basically, they're not flabby like this. They're like moving around like very stiff. And that's what's happening with this. Okay? Symptoms first appear in the 30s. They usually die about 10 to 20 years later. All right? And there is really no treatment except just supportive, okay, on something like this. Okay, now substantia nigra. This isn't a disease. This is part of the basal ganglion. We're going to lead to something with this. Substantia nigra, it stands for black substance. And what it is part of the basal ganglion that controls the initiation, termination, and unwanted movements. So what does basal ganglion do? Right? See, I wanted to do that, and I did it, and I want to do it again, but something's holding me back from not doing it. The basal ganglion. The basal ganglion is preventing me from not doing that. Okay? That's what's going on with this. All right? If the basal ganglion is working, you're not going to do these unwanted movements. Now, with something like this, it also has to do with unwanted things you want to say. There's probably something to do with that too, and I'm not too sure with that.
Okay.
But because you could also be manic and be very impulsive too. Just spending money just for the heck of it.
But like in a sound mind person,
It could be. It probably has something that's just going to contribute somewhat.
Okay.
All right? But it can also deal with words that you say. All right? I bet there's a bunch of things after that exam you want to tell me. If something's holding you back. You know what I'm saying, right? All right? Well, people with Tourette syndrome, it would just come out. All right? So in Tourette syndrome, there's going to be some basal ganglion deficit that's happening there. Okay? What happens with this basal ganglion or the substantia nigra, the neurotransmitter here is going to be dopamine. So if there's something wrong with the substantia nigra, it gets destroyed, the dopamine does not come out. Okay? So this leads to a disease called Parkinson's, which I'm sure most of you have heard about this. Parkinson's is when there's damage to the SN and substantia nigra, so there's something wrong with the neurons in the substantia nigra. That means that there's going to be a decrease in dopamine secretion. When that happens, then you're going to have an increased activity of the basal ganglion. Okay? Initiation and well, not so much the determination, but you're going to have these unwanted movements that are not going to be stopped. So you're going to have gradual increase in muscle tone. It's going to be very rigid. Muscle tone is pretty tight. And what happens is you get these classic Parkinsonian symptoms. Tremors, slow movement, inability to move. You get a very reduced, we call it flat effect. Their face is like showing no expression. How you doing today? I'm fine. I just had a birthday early this morning, and it's just dandy. I just feel really good. Just a very flat effect. Okay? But they have, and they also, when they walk, they're very slow, but very rigid, and they have this classic, what we call pill rolling movements with their fingers. He's rolling, like you had a pill in your fingers over here, and you're rolling it, and they kind of make those movements. And you probably saw it in some movies. Okay? So this is what happens. So it's chronic degeneration disease. Because the substantia nigra is destroyed, you're not going to have dopamine. Dopamine is needed so that it's going to prevent these unwanted movements. So how would you think to treat this? What would you give that person? Yeah. What? We won't go into the Dr. Oz stuff, but I know what you're saying. Dopamine. Yeah. That's what it is. We're going to get dopamine. Now, here's the problem. You guys learned about and you're going to, and this isn't about a pharmacology course, but there's something called levodopa, okay? Levodopa, which is L-dopa, and I'm not going to ask you about this, but I want you to understand why we got to go over this so that when you get to pharmacology, it'll all be put together. I want you to go over there and say, you never taught Parkinson. This is why you need to know it. You have a blood-brain barrier, and that's a double-edged sword. The blood-brain barrier is so good that it's not going to allow certain viruses and bacteria to get into the brain. That's wonderful. The problem is it is so darn good that it's also going to limit what medications could get into the brain also. So here you are going to load up this person with L-DOPA, and you would want all of it to go up to the brain, and it would work. However, only 5 to 10% of it actually gets into the brain. Now, what I didn't tell you is that you have dopamine receptors elsewhere in the brain and also all over your body. So now only 10% go up to the brain where it's supposed to go. The other 90% turn on all the other dopamine receptors, and you're flooding them, and you start getting other symptoms. These symptoms that you get is these uncontrollable, worse movements than what it would be for Parkinson's. So we call this dyskinesia, these uncontrolled, and they get pretty bad. So this L-DOPA medication is only good for maybe the early signs. After that, these movements get so drastic that you have to stop the medication because it only goes, 10% only go up to the brain. The other 90% goes elsewhere. All right? So this is basically that walk I was telling you, very stiff, slow gait. All right? The pill rolling movements. All right? Their face, it's like they're very, that flat effect. All right? But you could also have these big movements. So these people over here, who here knows Danny Thomas? You might know his daughter, Marlo Thomas, or he was he had his own sitcom back in the 1950s and 60s. But what TV, or what actually charity for children, hospital charity, did he actually start, and his daughter is actually the spokesman for it? No, you know what it is. St. Jude's. So he's the one that started it all, okay? This guy, I'm sure you know, he's now the spokesman of Parkinson's. I've known him as Family Ties. You probably know him as Back to the Future, right? This guy up here, he was in a lot of horror movies back in the 60s, but you probably know his voice. Michael Jackson's Thriller. When he did that monologue, that's him talking. All right? He was also in, his last movie he did was Edward Scissorhands, and he was the father who actually created Edward Scissorhands. Pope John Paul II, and one who just recently passed on was Muhammad Ali, right? You've learned about the Parkinson's. He got Parkinson's because of how many times he's been bashed in the head and probably just destroyed the basal ganglia. But here he is in his prime. Well, look at him. Look at that flat effect on his face. Right? That's the way he was over there. It's just a flat effect. So that was so that's people who have that. Also, there's a movie, okay, called Awakenings. This is how the true story of how L-DOPA started back in 1969, I think, where Robin Williams. It's not a comedy, but Robin Williams was the doctor, and Robert De Niro was the patient with Parkinson's, and he did an awesome job of presenting someone with Parkinson's. But this is a good movie. It explains how the whole L-DOPA is. And if you don't understand about why we had to stop the medication at a certain point, this will show it. You'll see what it's all about. But don't watch it now. Watch it after the semester, after our course. We have more time. So, all right. So cortical spinal tract. All right. Again, we did this already, but I want to show you because we're going to get into another disease. So really brief scenario again. This is motor. It starts on the frontal lobe, all right? Let's say it starts on the right side. We have one on the left side too, but it starts on the right side. It goes down from the frontal lobe as an upper motor neuron, gets into the brain stem, and crosses over to the left side, and goes down the spinal cord, still as an upper motor neuron, until it needs to synapse with another cell, all right? In the gray matter, the anterior gray matter. When it leaves there, it leaves as another neuron called a lower motor neuron. All right? So you have it starting in the frontal lobe. Goes down through the brain. When it gets to the brain stem, it crosses over to the other side. goes down to wherever it needs to go. If it goes to my arm, goes to my leg, wherever it needs to go, it is going to synapse in the anterior great horn of the spinal cord, and it's going to synapse with the lower motor neuron to go out as a peripheral nerve to wherever that skeletal muscle is that it needs to do. So this is all motor. And that's why if you had a stroke of the right side, you can't move the left side because of the crossing over here. Okay? We clear with that? You have upper motor neuron and lower motor neuron. So that brings about ALS. All right? Amyotrophic lateral sclerosis, ALS, better known as Lou Gehrig's disease, because Lou Gehrig was known, that's what he died of. You also have, who's this guy? Stephen Hawking, okay, who has it also, right? He's our Einstein of today. So what happens with this, it's idiopathic. We don't know what causes it, but this is where you're going to have chronic progressive destruction of the motor neurons, all right, the cortical spinal tract. This is where it's going to be the upper motor neuron and the lower motor neuron being affected. Okay? We talked about this and know the difference between this one and polio. Okay? But in this case, it's the same thing with the two. Sensation is intact. All right? So sensation is working. It's the motor. Like I said, this is just motor. It's just descending. That's what gets attacked in here. Sensation is fine. So again, it's about bedside manners. You have somebody who has ALS, all right? You have a patient, your mother, your sister, right? Hold their hand. You're not going to get them to squeeze you back, but they will feel you. And that's important, so that you're there at the bedside holding their hand. They feel that. You touch them, their eyes will open, and in their own eyes, their words will say thank you, all right? But they won't, it's like that fly that's on them, they feel it, but they can't swat it away, okay? And that's what's important with this. Again, they usually die of respiratory arrest. The diaphragm muscle usually is not going to function anymore. Okay? All right, just neoplastic diseases, all right? Just a few things, cancers here. First off, mature neurons, they usually don't turn into cancer because they have an extremely slow turnover rate. In certain situations, they will turn over, but it's very rare should that be. It takes like 70 years for that to happen. So therefore, these just don't turn into cancer. We do have immature neurons. They do cause cancer, very rarely, but they do cause cancer. These are in children when the neurons are still developing. And the one that you should know is something called neuroblastoma. Neuroblastoma is a cancer of immature neurons in children. Okay? Majority of the cells that become cancerous in the brain are going to be the neuroglia, not the neurons, but the cells, like the Schwann cells and the oligodendrocyte and the ependymal cells and the astrocytes and all those neuroglia cells. They're the ones that actually will cause cancer. Other tissues that can be found in there that are not neuroglia is like your pituitary gland. Well, that's a gland, which means it's epithelial. It's not neurons. So that, too, can actually become cancerous, whether benign or not. Usually it's benign. Okay? So you have brain metastases is the most common tumor found in the brain. 2/3 of tumors that are found in the brain came from someplace else. So yes, think about it. If they do if they do a CT scan of the brain and they find a tumor there, they're going to actually do some sort of other kind of CAT scan to see if there's other places that you might have cancer, namely the lung, breast, and melanoma, which is skin cancer. Those are the most kinds of cancers that will metastasize to the brain. Gliomas is the most common primary brain tumor. Okay? And their tumors usually have astrocytes, oligodendrocytes, or ependymal cells. Okay? And they could be malignant or benign. And these few charts over here kind of show you what they are. Ependymoma is ones that actually line the ventricles. These are ones that actually make cerebral spinal fluid. So in something like this, what we normally see with something like this is someone having a lot of cerebrospinal fluid being built up because of this tumor. So you're putting it together. This can cause hydrocephaly, right? So it's got this chart here and this chart over here. Okay? So that's the nervous system.